morning, everyone. So my group, our goal was to develop the content about acute respiratory symptoms management in these chronic respiratory patients. So my team is Luís, Serafim, myself, Pedro, and Helena. We are from Atlântica, Portugal. So what we identified first. Again, this work is co-funded by the European Union, this project. So in chronic respiratory disease, we all know that the patients somewhere in time they will have exacerbations over their signs and symptoms regarding to their disease. So and that will lead to an increase on hospitalizations, increase on symptoms like dyspnea, fatigue, secretions, and also, of course, combined with a diminishing of the quality of life of the patient. So our job is to understand how can these factors be manageable? What can we do specifically, exactly? What does the literature recommend us to do in these situations? So it's important to know which kind of patients are these. And the data suggests that this recent data suggests that we have 79.7 deaths per 1,000 inhabitants in Europe. The main cause of these deaths are acute respiratory symptoms are related to smoking and occupational risks. And the higher death rates come mainly in men and elderly people over 65 years old, so male over 65 years old with this smoking and occupational risks are the most risk population to develop respiratory disease and to have the increase on acute respiratory symptoms. Again, the main pathologies that we identified were the respiratory syncytial virus, the influenza flu, the coronavirus 19 that appeared a few years ago, the community-acquired pneumonia, chronic obstructive pulmonary disease, so COPD, asthma, and idiopathic pulmonary fibrosis. The major symptoms, as to the major symptoms of this respiratory disease, it's common among them all. Patients refer dyspnea, secretions, and also a very important decrease on the tolerance of effort and exercise. So the strategy most commonly referred is the pulmonary rehabilitation, which involves a set of procedures that relieve the symptoms patients. Besides that, this pulmonary rehabilitation is described as a way of decreasing the hospital admission rates, provide a better control of the patient's symptoms, and very important as well, self-management of symptoms for the patients. So they can understand what to do and when in terms of if a crisis appeared. As to recommendations for better clinical practices, we identified that it's important to have an increased number of specialized centers where pulmonary rehabilitation can happen with certified, qualified professionals to do it. And of course, to differentiate the intervention setting options. Either it's tele-rehabilitation or home-based rehabilitation. This will provide different strategies will allow us to reach more patients depending on their social status, their limitations in going to the specialized centers, etc. As specific clinical strategies, we observe that education is very important. The patient must understand the full scope of his disease in order to self-manage it. Breathing exercises come as standards to promote this increase of quality of life itself, because it relieves some symptoms. And very important as well to teach the patient energy conservation techniques. So these are postures that the patient can adopt during a crisis, or even strategies like at home to have the things that he uses the most close to him in a reachable distance, so that the tolerance to effort is minimized. And those are the main conclusions for now, for our part. And if you have any questions, I can answer them. Thank you.
Thank you, Pedro, very much. That was interesting presentation, and we wish you new interesting insights.
Hello, everybody. It is a very big pleasure for me to have a possibility to present our experience connected to BREF project. I would like to let me start to saying a few words about my background. My name is Agata Mroczek. I am from University of Opole. I am a professor assistant and researcher. I am a physiotherapist. My specialization is physical activity, movement therapy, and exercise. As you can see on the screen, I would like to tell you something about the physical activity in chronic respiratory condition. This is the table of context. My presentation is structured as follows. First of all, I would like to give you an overview about the definition of physical activity. Next, I will focus on recommendation, benefits of physical activity, types and intensity levels of physical activity. Then I will go to review of tools for assessment physical activity in patients with chronic respiratory diseases and barriers of physical activity in chronic respiratory condition. The final step will be to raise the barriers of physical activity in chronic respiratory diseases. I would like to show you the definition of physical activity, which is recommended from World Health Organization. Physical activity is any bodily movement produced by skeletal muscles and requires energy to do this movement. We can say stuff like that physical activity is any movement by, for example, during the leisure time, for transportation, and as occupational physical activity. Physical activity is proven to help prevent and manage many diseases such as diabetes, cancer, for example, and stroke. And also it helps to prevent hypertension, maintain proper weight, and improve mental health, quality of life, and as well as well-being. Now I would like to show you a recommendation of World Health Organization physical activity for adults and older adults with chronic respiratory condition, aged over 18 years old. The people should do at least 130 minutes moderate physical activity, or 75 to 150 minutes vigorous intensity aerobic physical activity, or combination of two physical activity levels like vigorous and moderate. And sometimes we have this kind of situation that the patients with chronic respiratory diseases, they are unable to make this criteria recommend the physical activity guidelines. We can recommend them to start with small amounts of physical activity and gradually increase intensity and duration over time. Regular physical activity can help people improve, for example, cardiovascular health, for example, maintain healthy heart and blood vessels, reducing the risk of cardiovascular disease. Also, it's help with weight management. Physical activity aids in weight control by burning calories and increasing metabolism. Also, mental well-being, because of physical activity, has positive effects of mental health, reducing symptoms of depression anxiety and stress. Prevention of chronic disease is also very, very important. About the types of physical activity, we have various types of physical activity, including aerobic, muscle strengthening, flexibility, and balance exercise. Can be incorporated into a fitness routine. For example, aerobic physical activity include walking, jogging, cycling, or swimming. Muscle strengthening exercise examples include weight lifting, resistance training, and body weight exercise. Aim to improve muscle strength, endurance, and tone. Flexibility exercise, stretching, for example, yoga and Pilates, improve flexibility, joint mobility, and muscle elasticity. And balance and coordination exercise, for example, Tai Chi, reducing risk of falls. There is the goal of this kind of exercise. The intensity of physical activity can be ranged from the light through moderate and vigorous, depending on individual levels of the end goals. For example, light physical activity, moderate, and vigorous. It always depends of people and their background with physical activity before, for example, diseases. How to measure physical activity in patients? We have general physical activity assessments and tools, and also specific for chronic respiratory condition. Here you have, for example, International Physical Activity Questionnaire, the long version and short version. We have also Physical Activity Scale for Elderly, LASA Physical Activity Questionnaire, and Daily Proactive and Clinical Visit Proactive Physical Activity, the Brief Physical Activity Assessment Tool, and also cystic fibrosis decisional balance for physical activity. In many scientific research, we can find this kind of assessment tools, which it helps to measure. Of course, it is the declaration about the physical activity about the patients. We know that physical activity play very, very big role in chronic respiratory diseases, but the people due to breathlessness during the physical activity and reduced exercise tolerance, the patients with COPD sometimes didn't met the criteria about the physical activity and adopt to the sedentary lifestyle. And also we can find a lot of barriers with physical activity in chronic respiratory diseases, for example, sociodemographic variables, also psychological or social factors. For example, the barriers, they are older age, gender, education, and another factor, for example, like fear of breathlessness, and for example, lack of motivation, anxiety, and depression from the psychological factors. In conclusion, I can say that physical activity play very, very big role in patients with chronic respiratory diseases, and help to prevent, for example, depression or improve mental health and well-being. Thus, for promoting of physical activity and healthy lifestyle is very important to management with patients with chronic respiratory disease. And the part of BREF project is to give the also advice and good practice about the physical activity, which can we recommend for patients with chronic respiratory diseases. I would like to thank you for the attention. If you have any question, I will happy to answer them.
Thank you very much, Agata. Well, it was nice presentation with a lot of useful information.
Welcome everyone. The topic of my presentation is quality of life in patients with chronic respiratory diseases, review of tools. I am from University of Opole. I work at the University of Opole as assistant professor, and I'm also a nurse. What do we know about quality of life? Why quality of life is important? Quality of life has become a key goal of contemporary healthcare. It's highly relevant for patient care. It directly influences therapy satisfaction and patient's compliance, but it's also very strong predictor of treatment success and of patient survival. Quality of life. Why the research of quality of life is important? Because it favors empowerment of the therapeutic process, provide data on the patient's situations, and allow to see the patient's problems from his point of view. What do we know at this moment about quality of life? We know that there is a very subjective and multi-dimensional concept. We know that there are many definitions of quality of life and different approaches to the quality of life, but many researchers at this moment agree that quality of life assessment should take into consideration multiply domains, and at figure 1 we see 5 domains in a conceptual definition of quality of life. Yes, quality of life taking into consideration psychological status, physical status, social interactions, economical factors, and spiritual status. Chronic respiratory disease such as COPD, such as asthma, cystic fibrosis, interstitial lung disease, and lung cancer impacted the quality of life because of symptoms like breathlessness, reduced lung function, fatigue, and all. Which factors affecting quality of life among patients with chronic respiratory disease? Dyspnea, longer duration of illness, comorbidities, older age, the use of oxygen, the occupation of patients, and employment status. The tools which we use, by which we can assess the quality of life of patients, we can divide it into 2 groups. General questionnaires for examining quality of life and specific questionnaires related to the health of illness. And at the next slides, I try to talk something about each of them, a few words. The World Health Organization quality of life. Such questionnaires consist of 26 questions and measure quality of life within 4 domains: physical, psychological, social relationships, and environmental domain. Each aspect is assessed on at the 5-grade scale, from very bad to very good, and the higher the score means the higher the quality of life. At the bottom of the slide, I put the link, and at this link you can find these questionnaires translated into many languages, and they are validated. So I think that it will be very useful for everybody. Euro Quality of Life questionnaire is developed in Europe and widely used, and consists of 5 areas, 5 dimensions like mobility, self-care, usual activity, pain, anxiety, depressions. And at the bottom you also see the publications which described such a questionnaire. More information. The next questionnaire, sorry, some technical problem. The 36 item short form survey measure quality of life based on the last 4 weeks. Such questionnaire comprises of 36 questions that cover 8 domains of health. Results is obtained in the form of a 600-point Likert scale from 0 to 100, and the higher scores mean better quality of life. Next is the short form 12. It consists of 12 questions that measure 8 health domains, and the main indicator is physical component summary, and the second is mental component summary indicator. Yes, and there are domains in physical health related like general health, physical functioning, role, physical and body pain, and in the area of mental indicator, we see 4 domains like vitality, social functioning, role, emotional and mental health. Very known is St. George's respiratory questionnaire, and is relevant for patients with asthma, COPD, bronchiectasis, interstitial lung disease, and many others. Such questionnaires analyzes the impact of chronic respiratory disease on the patient's daily activities. Such questionnaire includes 50 items and covered 3 domains like symptoms, activity and impact. Impact means psychosocial effects of the disease. Asthma control test is very simple tool, is easy to complete it by the patients, and is very useful for clinical practitioners. The scores in the asthma control test range from 5 to 25, where 25 points means total the best control of patients, control of symptoms, of course. Asthma quality of life questionnaire is the next tool for assessing quality of life among patients with asthma. We have such tool in two versions. One of them is for patient, and the second is for medical personnel. It includes from 32 questions and cover 5 domains. The Living with Asthma questionnaires consisted of 68 items and covers 11 domains of asthma experience. We assessing by using it such areas like practicing sports, sleep disorders, professional work, and leisure activities time. Completing the questionnaire takes approx 20 minutes. Yes, and the asthma impairment and risk questionnaires is the next questionnaires. consisted of 10 items, very simple yes, no asthma control tool. It must be used regarding to older to the aged to the children aged 12 years and older, to the aged and older, yes. And the COPD assessment test is also very known tool. Is designed to measure the impact of COPD on a person's life and the risk of disease exacerbation. It's very short, but it consists only of 8 items. And the elements to be assessed are symptoms such as coughing, such as sputum retention, sleep quality, etc. Quality of life in patients with idiopathic pulmonary fibrosis, it's the next tool, comprises 42 items and cover the 6 scales, like conditions of patients, impairments, problems, shortness of breath, cough, and health status. The final calculation is carried out by adding up the raw values to a total value from 0 to 198 points. Of course, the higher the score represents the better quality of life. The University of California, San Diego shortness of breath questionnaires. It's a self-report questionnaires for patients which indicate the severity of shortness of breath during 20 different activities of daily living. It includes 44 items, and the total score ranges from 0 to 120, and the higher the score indicating more severe dyspnea. And the last one is DSAP Kids questionnaires. The DSAP Kids is a chronic generic module and consists of 37 items, assigning 6 dimensions, but we have also disease-specific cystic fibrosis questionnaires, consist of 2 domains. The impact domain is the first part of the questionnaires and consisted of 6 items, and the second part of such questionnaires is the treatment domain and cover 8 items. And thank you very much for your attention. This is my email. Thank you very much.
Thank you very much, Katarzyna. I believe that it's very valuable result to have that collection of research questionnaires, and they can be useful both for researchers, for students, and it's easy to have this evaluation, short descriptions. It's easy in the way for choosing the right instrument. So thank you.
Hello everybody, my name is Antonina Kaczorowska. I'm from University of Opole. I'm assistant of professor, researcher and physiotherapist. My topic is quality of life in chronic respiratory disease and its determinants. This is a review of research. Quality of life is a widely researched term for respiratory disease, and it allows the impact of the disease of the patient's life to be assessed through the patient's perception. Chronic pulmonary diseases affect health-related quality of life. Asthma is a chronic respiratory disease that affects the physical and mental health of people around the world resulting in a reduced learning efficiency, reduced physical activity, and quality of life. The quality of life of people suffering from asthma is much lower than the quality of life on the general populations. Patients who perceive their life and emotions as seriously affected by the disease are more likely to have a lower quality of life. Mild and moderate asthma affect patients' daily lives to a lesser extent and reduce their quality of life than severe asthma. Asthma affects adult quality of life through social. Asthma significantly affects the quality of vision and pain. Asthma affects adult quality of life through emotional, social, physical, and occupational impacts. Better follow-up and patients' education may be necessary in the future to halt disease progression and achieve ideal therapeutic outcomes. The COVID-19 pandemic negatively affected stress, anxiety levels, sleep, and quality of life in asthma patients. During the pandemic, asthma patients were less active than healthy people, and therefore, the pandemic had a greater negative impact of their quality of life. In order to minimize the effect of limitation and psychological burden caused by the pandemic and to encourage asthma patients to be physically active, it is very important to conduct research on controlling stress levels and improving the quality of life and sleep of asthma patients. Quality of life in COPD. Chronic obstructive pulmonary disease has been recognized worldwide in recent years as a major health challenge that affects various aspects of quality of life. COPD often leads to progressive airway obstruction and difficult breathing. The disease significantly reduces patients' quality of life. Poor quality of life is associated with a range of adverse health outcomes in COPD, including exacerbations, hospitalization, and mortality. The most favorably rated indicators are vitality, sense of mental health, and social functioning. The most poorly rated indicators were limitation by physical emotional role function. Skeletal muscle dysfunction leads to reduced activity in patients with COPD. As an essential part of COPD treatment, pulmonary rehabilitation in COPD alleviates dyspnea and fatigue, improves exercise tolerance and health-related quality of life. Cystic fibrosis is a life-limiting genetic disease in which thick mucus builds up in the lungs, leading to infections, inflammations, and ultimately a decline in lung function. Cystic fibrosis significantly reduces patients' quality of life. Children and young adults with cystic fibrosis experience significantly more physical limitation, negative emotional health effects of the disease, and social exclusion. Assessment of adult patients' quality of life showed impaired levels of quality of life in the subject, particularly in the domains of vitality, social perception, body image, treatment burden, and health perception. People with this lung transplantation results in improved health-related quality of life in patients with cystic fibrosis compared to their initial conditions. Up to 5 years after surgery, patients with cystic fibrosis maintain a quality of life similar to that of the general population. A patient with interstitial lung disease, the quality of life of patient with interstitial lung disease systematically deteriorates at varying rates. Patients score least on vitality and physical functioning, and better on mention functioning. One of these diseases is idiopathic pulmonary fibrosis. It's one of the most common forms of interstitial lung disease, occurring in people aged 50 years and older. Idiopathic pulmonary fibrosis has a significant negative impact on health-related quality of life. The domain of life most reduced was the domain related to physical function. The domain related to emotional and mental functioning were at a higher level. There are many studies of the symptoms and complications of COVID-19, but the aftermath of COVID-19 is not well understood, and a few studies report on lingering symptoms and quality of life. A post-acute COVID-19 syndrome is associated with poorer quality of life, persistent symptoms including fatigue, shortness of breath, anosmia, sleep disturbances, and poorer mental health. This suggests that more research is needed in post-acute COVID syndrome patients to understand the risk factors that cause it and ultimately lead to poor quality of life. And what are the determinants of quality of life in chronic respiratory diseases? The one of determinants is patient's perception of their disease control, and emotional response. And the more severely patient perceive their illness, the more it affected their lives. The greater the respondent's emotional response to their illness, the lower the quality of life. Patients who declare control over the illness and adherence to medical recommendation had a better quality of life. The occurrence and severity of symptoms associated with the disease is the next determinant of quality of life. Wheezing, chest discomfort from coughing, and discomfort from avoiding going out of the house were associated with lower quality of life in asthma patients. Lung functional status showed an association with quality of life in children and adults with cystic fibrosis. Cough and snow were significantly associated with quality of life in patients with interstitial pneumonia. In severe COPD, bronchial obstruction became an important determinant which reduced quality of life. Acute exacerbations of COPD have a long-lasting and significant impact on patient impaired lung function and function of the health-related quality of life. The next determinants are comorbidities. The quality of life with chronic respiratory disease is affected by comorbidities. One disease that significantly reduces patients' quality of life is depression. The presence of depressive symptoms coexisted with poorer quality of life in patients with asthma. The presence of depression and anxiety was negatively associated with quality of life in patients with cystic fibrosis and interstitial pneumonia. The presence of comorbidities such as gastroesophageal reflux disease, osteoporosis, diabetes, hypertension, heart disease, degenerative changes, and sleep disturbances reduce quality of life of patients with asthma. Psychiatric disorders and alcohol abuse had the greatest negative impact of patients' quality of life with patients with COPD. These comorbidities had the greatest impact of quality of life in the early stages of COPD. Other factors such as low income, physical inactivity, smoking, and underweight and obesity negatively affected the quality of life of patients with asthma. Sex can affect the quality of life with patients with respiratory disease. For example, women with COPD had a lower quality of life than men. Fatigue negatively affected the quality of life of patients with chronic respiratory disease such as asthma, COPD, obstructive sleep apnea, and bronchiectasis. The negative impact of fatigue on quality of life indicates the need for careful and routine assessment of this symptom in pulmonary patients. An important factor to improving the condition of patients with chronic respiratory disease and quality of life is pulmonary rehabilitation. Pulmonary rehabilitation is effective, recognized therapy for improving exercise intolerance, impaired quality of life. Pulmonary rehabilitation based of physical effort, aerobic training, respiratory exercises. Improve asthma control and quality of life in patients with asthma. An exercise-based program should be recommended as an adjunct therapy for the treatment of asthma. Pulmonary rehabilitation in COPD improves health-related quality of life. Exercise is a key component of rehabilitation. Pulmonary rehabilitation improves exercise capacity and the quality of life in patients with idiopathic pulmonary fibrosis. Physical activity positively correlated with quality of life in children with cystic fibrosis. Many factors are associated with health-related quality of life in patients with chronic respiratory diseases. To improve quality of life among these patients, consideration should be given to providing strategies that address potential risk factors. Thank you for your attention.
Thank you very much, Antonina. It was nice to see you here. Yes. Thank you for sharing interesting insights. For those who don't understand pulmonary disease as well, I believe now they can understand the determinants of quality of life better and understand why relieving some conditions is so important and why we're having this project. Okay, and now we have the last presentation. It was supposed to be presented by Marija Ljubičić from Zadar University, but it happened that yesterday's flight of Maria was cancelled, and she's on plane right now. So yesterday she took the chance to record the presentation, and we're having the recorded presentation.
Hello everyone, I'm Marija Ljubičić, assistant professor at University of Zadar, and together with my colleague Ivana Gusar, assistant professor at University of Zadar, and Zvijezdan Penezić, full professor and vice-rector at University of Zadar, Croatia, we present lifestyle and pulmonary disease. Before the start, we will transfer greetings from our beautiful Croatia, our beautiful city of Zadar, which has a century-old university tradition. Also, we would transfer greetings from our University of Zadar, today the largest integrated university in Croatia with 27 departments, also with more than 5,000 students and more than 600 employees. Also, University of Zadar has more than 100 different projects. In this presentation, we talk about lifestyle and motivation for health behavior. We talk about unhealthy lifestyle and association between pathophysiological mechanisms. We talk about physical activity and its implication for pulmonary disease. Also, we talk about effects of healthy diet on the prevention of pulmonary disease. In this presentation, we talk about stress mechanisms, oxidative stress, sleep deprivation, many risk factors, for example, smoking, alcohol and drug dependence, and also mental health and their association with pulmonary disease. We talk about rehabilitation of patients who are suffering from pulmonary disease. Many chronic diseases, among which are also chronic pulmonary disease, are the results on unhealthy lifestyle, for example, physical inactivity, unhealthy diet, stress, insufficient sleep, smoking, and lack of positive social relationship. Many studies confirm association between these unhealthy lifestyle habits, many pathophysiological mechanisms, and also development of chronic disease. Study also confirms that healthy lifestyle habits can prevent the development of many chronic disease, especially in this case pulmonary disease. In that way, healthy lifestyle habits may have a positive impact of global health and overall quality of life. Lifestyle is one of the most important ways to prevent and or treat chronic modern disease. Lifestyle describes as way of person or group of people live their lives, including their regular routines, daily habits and choices. People need to be motivated to adopt healthy lifestyle, but sometimes this is not so easy step for many individuals. For example, sometimes people know that they do something wrong, that they need to change something, but they do nothing. A lifestyle medicine, for example, lifestyle intervention, often used therapeutically to improve health and quality of life. Unhealthy lifestyle contribute to pathophysiological mechanisms such as oxidative stress, such as hormonal dysregulation, many metabolic disorders. In that way, cause chronic disease, for example, cardiovascular disease, hypertension, obesity, cancer, mental disorders, and in our case, may cause pulmonary disease. All these conditions may cause disabilities and even death. Because of that, unhealthy lifestyle habits have negative effects on physical and mental health and generally in quality. Physical activity is a very important predictor of pulmonary disease progression. For example, in patients with pulmonary disease, lower level of physical activity associated with high risk of hospitalization and high risk of disability and even death. Many studies confirm that physical activity has preventive effect to the treatment of all pulmonary disease. Unhealthy diet also have negative impact on pulmonary health. For example, study confirms that dietary habits can protect respiratory health. Patients with pulmonary disease who follow the, for example, Mediterranean diet have better lung functions. Because of that, it is recommended to increase the consumption of high fiber products and also Mediterranean diet in general. Pathophysiological stress also increase pathophysiological mechanisms. In that way, impair mental and physical health. For example, cortisol as a primary stress hormone associated with many negative health outcomes. For example, hyperglycemia, insulin resistance, higher advanced glycation end products, and higher oxidative stress. All these conditions, as already mentioned, may cause chronic disease, may cause chronic pulmonary disease. It is extremely important to adopt constructive personal development methods. In that way, provide the healthy lifestyle and prevent chronic pulmonary. Many people has sleep problems and sleep less than recommended for optimal sleep. This may also have negative impact on human health. Chronic pulmonary disease, for example, and sleep is very closely associated. For example, chronic pulmonary disease often contributes to the sleep disturbance and vice versa. Sleep deprivation associated with high risk for autoimmune, metabolic, and neurodegenerative illness. Also, study confirm that 150 minutes of physical activity per day may have positive effects on sleep regulation and also in that way on the human health. We know that smoking, that alcohol, and that drug dependence are the risk factor for pulmonary disease. For example, smoke associated with many inflammatory responses, with higher cortisol level, with higher oxidative stress, and many pathophysiological mechanisms. Also, many these negative lifestyle habits increase the development of many chronic and many malignant pulmonary disease and many other diseases. For patients who are suffering from pulmonary disease, rehabilitation is one of the most successful interventions to help the patient to live active, to improve their life, their quality of life. Because of that, rehabilitation needs to be high quality, because only in that way this method helps reduce the respiratory complication in this patient. Before the end, we can repeat that healthy lifestyle makes an important contribution to the physical and mental health. But only if we change our own behavior, we can improve our own health. Because of that, it's necessary to apply a healthy lifestyle. In conclusion, all unhealthy lifestyle habits associated with pathophysiological mechanisms and have negative impact on human health and also may cause chronic pulmonary disease. It is extremely important to make lifestyle changes and that way improve public health. What we can do? First, patient should realize that lifestyle changes are important to their life, their health. For the professional, for the health professional, it is important that they should find the method to incorporate all these recommendations into the patient lifestyle. One of these methods is our project Breath. This is our reference. And again, greetings from our beautiful city of Zadar, and thank you for your attention.
Even though Maria is not here with us, best wishes to Zadar. And I thank you everyone for attending here on site and online. Thank you everyone who will watch the record of this session. Hopefully you gained some new knowledge, you learned something for yourself, for your patients. And if you wish to learn more about the project and review our results, please once again visit breath.ku.lt. Thank you.